Hello everyone and welcome to Cardiology Review for the Internal Medicine Boards. I'm Laurel Toft, formerly known as Laurel Brown, and I'm excited to be doing a new format of lecture with you, recorded here from the comfort of my home. As many of you are aware who might be studying for your board exam or who have looked at the ABIM website, cardiovascular disease is the single highest represented discipline on the board exam. So it really behooves you to know how to answer these questions and therefore to watch my lecture in its entirety. These are the topics listed under cardiovascular disease on the ABIM website. These are broad categories. There are specific disease states underneath each of these ones. We are not going to cover absolutely everything on this list, but we're going to get to a large portion of it and kind of the high yield topics. But it does behoove you to go and look through the topics and make sure that you're comfortable with all of them. We're going to look at some major categories: cardiomyopathy, arrhythmia, ischemia or atherosclerosis, valvular disease, and then some miscellaneous. This is going to be a little bit different of a lecture than what you've seen from me before. This is designed to be a board's review for you, and we're going to be using board-style multiple choice questions to prompt the discussion. So my suggestion is that you pause when I have put up a question. Pause the lecture, read the question, and pick an answer for yourself. Now keep in mind that the actual board's questions will have longer stems than what I have provided here. And on the boards, you have 120 seconds or 2 minutes per question. So I suggest that you time yourself and give yourself no more than 60 to 90 seconds for each of my questions. And then once you've picked an answer, unpause, and the screen will then display the answer and my discussion. Okay, so remember, pause, choose your answer, unpause to have a discussion, and in this way we're going to review a lot of these topics. Okay, so although the boards will not give you a heading about what they're testing, I am today. So first we're going to start in the category of cardiomyopathy. All right, so here's question 1. This is the part where you pause, read the question, pick an answer, and then come back. Okay, so this is a gentleman who is incidentally discovered to have systolic heart failure with an ejection fraction of 25%. When you look at his symptoms, he does get symptomatic after 2 flights of stairs. We would call him New York Heart Association Class 2 with this. He's already on some medications that you probably recognize as being guideline-directed medical therapy for heart failure. In this case, he was on them for hypertension, and that includes carvedilol and lisinopril. So although a lot of these options include medications that we use to treat systolic heart failure, per the guidelines, the best option for him is actually switching from lisinopril to the ARNI, which is the angiotensin receptor neprilysin inhibitor, sacubitril valsartan, otherwise known by the trade name of Entresto. Now, all of the other options are things that people might do in practice for the most part. Carvedilol, we would want to maximize it, but the reason not to is that his heart rate is only 50. Spironolactone does have an indication in systolic heart failure, but in this case, we really prefer to get him onto the ARNI, and we'll show you those guidelines next. Isosorbate mononitrate hydralazine combination has been shown to have mortality benefit in African American patients, but this man is white. Of note, you're only going to see the race in the stem if it is relevant to the discussion and the answer. And then finally, carvedilol and metoprolol succinate, that's the sustained release, are the 2 beta blockers that we use for systolic heart failure here in the United States. But really, carvedilol is actually in practice what most cardiologists prefer, and both of them are appropriate. So if we just remember about LV function, we have 2 categories of cardiomyopathy based on looking at the function of the LV. Systolic dysfunction, also known as HFrEF, which broadly is either ischemic or non-ischemic, and then non-systolic heart failure, which we sometimes also call HFpEF, but remember, not all forms of non-systolic heart failure are HFpEF. Under the systolic side, we have a lot of evidence for pharmacologic therapy. Under the non-systolic side, we almost have no evidence except for negative trials. That will change in the coming years as more trials are undertaken, but as of right now, we really don't have any specific medications to treat, in particular HFpEF. As a reminder about stages and classes, so there is heart failure stage, and then there's New York Heart Association functional class. Heart failure stage starts with A, which means you have risk factors, something like hypertension, but you have normal systolic function. Stage B, some structural heart disease, so your EF has started to drop but no symptoms. That corresponds to New York Heart Association Functional Class 1, which means you have no symptoms. You can go out and do all of the things. You can exercise, you can run a mile at the gym and have no symptoms. Stage C is structural heart disease with symptoms. And here's where we get to New York Heart Association Class 2 or 3. The majority of patients that you see will fall into one of these two functional classes. Class 2, moderate exertion, 1 or 2 flights of stairs. Class 3, minimal exertion, walking from the bedroom to the kitchen, slight incline. Stage D, refractory heart failure requiring specialized interventions. That usually corresponds to functional class 4, where they have symptoms even at rest. So these two staging and classification categories are very important to remember because the guidelines are based upon these definitions. When I think about the medications for people who have systolic dysfunction, which I'm counting as EF less than 40%, 40 to 50 is an intermediate zone. But these are going to be for people with EFs less than 40% for the most part. I break them down into broad categories in my mind. Diuretics and salt and fluid restriction are useful, but remember we have no mortality benefit proven studies, so these are really for symptom relief and potentially to decrease hospitalizations. The main classes that we use as first-line therapy include ARNI, angiotensin receptor blocker with neprilysin inhibitor. We're going to talk about the new guidelines for that. Beta blockers, mainstay of therapy, and then ACEs or ARBs. Most of your patients right now are going to be on ACEs and ARBs, but you'll see why we recommend switching them to ARNIs in a second. We also think about aldosterone antagonist, spironolactone, or eplerenone, if they still have symptoms once maximized on the other therapies, or in the acute myocardial infarction setting as an inpatient with a low EF. And then if they're African American, then we think about the isosorbide dinitrate plus hydralazine. And then I put on here in italics ivabradine, which is a relatively newer medication that does not have mortality benefit, but does have some benefit to reducing hospitalizations. So these are kind of the way that I think about them in terms of layers of how I'm treating them and what I'm accomplishing in particular. So this is an update from 2017 when our ARNI first came out. I've put up here the class of recommendation and the level of evidence. Those are good things for you to be familiar with as well for your boards. And what I want you to notice here is that on the top, so patients with chronic symptomatic HFrEF, New York Heart Association Class 2 or 3, who have tolerated an ACE or an ARB. This is exactly our man in the question. We should replace their ACE or ARB with an ARNI. So ARNIs are actually preferred because the mortality benefit appears to be higher in the study that was done. So all those patients of yours who are already on their stable doses of lisinopril or valsartan, it's time to be switching them over to sacubitril valsartan. The next recommendation, which again gets a class 1 level of evidence, A for ACEs and B for ARNI, is that they should be on at least something to inhibit the renin-angiotensin system. ACE inhibitors or ARBs or the ARNI. This is in conjunction with beta blockers, aldosterone antagonists in select patients. So this really statement tells you all the things you should be treating your patients with. But based upon this guideline, we really prefer to have everyone switched over to an ARNI as opposed to just keeping them on their ACE or ARB. If they cannot afford the ARNI or cannot tolerate it, ACEs or ARBs are also appropriate therapy. And then just important things to note about how you prescribe this medication. You do not give ARNI at the same time as ACE inhibitors. And you have to wait 36 hours after stopping the ACE inhibitor to start the ARNI. You have a much more potent blood pressure reduction with this class than you do with the ACE inhibitors, so you also need to have some blood pressure room in order to start it. And then finally, you should not give this to people with a history of angioedema. As you're aware, we often give people ARBs when they've had angioedema on ACE inhibitors because of the different pathways and buildup of substrates. But ARNI, we do not recommend that. If they have any history of angioedema, we don't give it. This is an updated flow algorithm for how to treat your patients with heart failure. And so step 1 is first you establish the diagnosis and you initiate them on beta blocker and ACE and ARB diuretics if needed. Then in step 2, we look and see what other qualifications or classifications they might have. We might see what their New York Heart Association functional class is and if they qualify for an aldosterone antagonist. If we see someone who still has blood pressure room and is tolerating the ACE and ARB, then we should discontinue the ACE and put them onto an ARNI. Here's our African American patients where we think about hydralazine and nitrates, and then we have some device therapy recommendations in here as well. And then finally, ivabradine is in yellow. This is a class of recommendation 2A, meaning you can consider it. And this is, again, for patients who have an elevated heart rate greater than 70 on maximally tolerated dose of beta blocker. Then you can consider giving them ivabradine. So this is a very good and useful flow chart to know for how we should do stepwise therapy for these patients. This is my personal chart that I use and how I think of them in my mind when I think of the class of medication. I think of whether or not it reduces symptoms, if that's my goal. I think of those with mortality benefit, including the ones that cause some reverse remodeling of the LV. Then I think of what is an add-on treatment if we still have symptoms. And then finally, remembering that inotropes worsen mortality, so that gets a special category in my mind. So this is just another way to organize these classes of medications if it's helpful to you. A word about device therapy. So there are 2 types of devices we should be thinking about in our patients with HFrEF. There's single chamber ICD, that's our internal cardiac defibrillator. This is to prevent sudden cardiac death. So the patients that get this, their EF is less than 35% and has stayed less than 35% despite being revascularized if they have ischemic disease and on optimal therapy. We usually require them to be on optimal medical therapy for 3 months before we put them in because we want to see if their EF raises above 35%. So that's one type of device. The other type of device is what we call a CRT, cardiac resynchronization therapy. You may have also heard it referred to as a biventricular ICD. That's what's actually shown in this picture here. We actually have 3 leads in this one, an atrial lead, our right ventricular lead with our defibrillator coil, and then over here we have our what we call our LV lead, which is in the coronary sinus. We don't actually put a lead into the left ventricle. This is for patients who have symptomatic heart failure, again, EF less than 35%, and a wide QRS with left bundle branch block. And by wide, it's not just 130 or 140, it needs to be above 150 milliseconds. So it would be very fair game to give you a question of a patient with New York Heart Association Class 2 heart failure, EF 35%, and show you an ECG that is a left bundle branch block with a QRS that you have to figure out is greater than 150 milliseconds, and the correct therapy for that patient would be a biventricular system. All right, next question. Again, pause. So this is a patient who now is discovered to have cardiomyopathy with a regional wall motion abnormality, anterolateral wall hypokinesis. They obviously have some little bit of edema as well and some volume overload. And the question is, what kind of diagnostic test should you perform? So you'll notice that several of these, like exercise stress echo, a regadenoson thallium stress test, or angiogram, are all trying to get at the question, does this person have ischemic cardiomyopathy? And in fact, every patient who is in that later adult years needs some kind of evaluation to see if their cardiomyopathy is ischemic when they're diagnosed with a new heart failure. The reason that we go for angiogram in this patient is because of his risk factors: diabetes, hypertension, tobacco abuse. This is a gentleman who has all the risk factors for coronary disease, and so you would not do a stress test which might give you a false negative. You would go straight for the gold standard, which is going to be the angiogram. Next question, here's where you pause. So this is a very classic situation that you might encounter. A person comes in after trauma, starts to have dyspnea and chest pain in the hospital, has some troponin elevation. You've all been called for this patient with the consult. The ECG shows some classic finding: diffuse T-wave inversions and QT prolongation. Notice nothing is said about ST elevations or depressions. The echocardiogram has magic words in here. There's a low EF, yes, but apical akinesis. That's the magic word to give you the diagnosis. And then they've already been kind to you and given you what the angiogram shows, which is non-obstructive coronary artery disease. So based on all of these, this is laying it in really thick, that although many of these are possible, particularly PE would be on your initial differential here, and with an older woman, this MI with no obstructive coronary artery disease, MINOCA, is also certainly possible. The best answer here is the Takotsubo cardiomyopathy, or what I like to call stress cardiomyopathy, in particular because apical akinesis, non-obstructive CAD, troponin in the right range, and the EKG that's classic. So to remember some of the features, this usually occurs after some kind of sudden stressor, emotional or physical. You do not always uncover that stressor when you're talking with the patient, but it's worthwhile to try. The troponin will be mildly elevated and usually out of proportion to the degree of LV dysfunction. In our question, the EF was 15%, but the troponin was only 0.7. Usually we'll see these troponins in that 5, maybe 10 range, as opposed to an acute MI that would drop your EF that low. You would see a ton of troponin because all those cells had died and leaked enzyme, as opposed to this reversible phenomena that we see in stress cardiomyopathy. So relatively low troponin. The ECG changes are classic. You can have ST elevations, but more often what we see is QT prolongation, deep symmetric T-wave inversions, and the ECG will evolve and then resolve if they're in the hospital long enough to see that. This is very classic and should raise this on your differential. The LV dysfunction is also not in a coronary distribution. So whereas with an anterior MI, we expect an anterior wall regional motion abnormality, in this case, we're looking for one of 3 classic patterns. Apical ballooning is the one you've all heard about, but there's also mid-ventricular ballooning, where the base and the apex squeeze, and the mid-ventricle is ballooned out, looks like a top that you would spin. And then basal ballooning is a little harder to appreciate, but the apex will squeeze and the base will be ballooned. These all can be consistent with stress cardiomyopathy. Everybody has to get an angiogram, and you will find no significant coronary disease to cause this exact degree of dysfunction. And then the LV dysfunction has to improve, although that is over the course of weeks to months, so you won't see that in the hospital necessarily, although you might. This is a great picture showing the apical ballooning variant. On the left, we see diastole when the LV is relaxed, and on the right, we see systole, where only the base of the heart is squeezing, and the entire apex, anterior all the way to inferior, is not squeezing, giving you that classic shape. Next question, pause. So this is a woman who is not doing well. She has both COPD and breast cancer and is on specific chemotherapy of doxorubicin as well as radiation therapy. She is tachycardic, hypotensive. I've given you an elevated JVD. The lungs are clear, steering you away from pulmonary edema, and there's no wheezing, so steering you away from COPD, and she's cold to the touch. Again, I've laid it on pretty thick here by saying low voltage ECG and a chest x-ray with an enlarged cardiac silhouette. So what you should be thinking in this woman is that she has a pericardial effusion and is likely going into cardiac tamponade. This question requires you to do 2-step reasoning to understand and remember what's the diagnostic test of choice for tamponade. And the most expedient bedside test, which should be done immediately, is the pulsus paradoxus evaluation. CT at the chest to look for a PE would be reasonable, but I've steered you away from that by showing you this enlarged cardiac silhouette and low voltage. Pulmonary function tests, not going to help us in the acute situation. A MUGA is a particular type of scan that was used at one point preferentially to evaluate the LV dysfunction when you had chemotherapy-induced cardiomyopathy, but again, that's a longer test, not in this acute setting. A TEE here would be overkill. You would definitely be ordering a transthoracic echocardiogram, but first you should be doing your pulsus paradoxus evaluation. So to remind us about cardiac tamponade, this is a case in which the intrapericardial pressure becomes greater than the intracardiac pressure, in particular on the right side where the intra-chamber pressures are lower. What happens is that you get impaired ventricular filling and on the left side, and that's going to decrease the cardiac output and eventually can cause hemodynamic collapse. Tamponade is a clinical diagnosis, so although the echo is helpful, you at the bedside really are the one that holds the key. The classic triad is an elevated JVP, distant or muffled heart sounds, and hypotension, although I say not always because you could have relative hypotension. I had a patient who was there with a blood pressure systolic of 130, and she was in raging tamponade. She normally had a blood pressure of 160. So you see that the relative diagnosis might be important. And then sometimes they're going to give you dyspnea or chest pain, and the pulsus paradoxus is our best bedside exam. So how do we do this? Okay, this is not really a paradox. This is an exaggeration of normal physiology. Normally, when you take a deep breath in, you lower the intrathoracic pressure, which increases venous return to the right side of the heart. The RV gets more volume delivered to it. The RV free wall over here is free to shift outward into that compliant pericardial space, and so it does so. In tamponade, let's go through the same process. Deep breath in, lowers the intrathoracic pressure, therefore increasing venous return. But now the RV, which is now getting a bigger volume load, the free wall is not free to shift out into the pericardium because the pressure in that space is too high. Therefore, the septum is going to shift over towards the left to accommodate the increased volume in the RV. As the septum shifts, that's actually going to lower the amount of volume in the left ventricle. Therefore, the stroke volume goes down, and that will lead to hypotension, decreased cardiac output, and eventually cardiovascular collapse. This is a great old drawing that I absolutely love, where you see on the left this tense pericardial effusion, and then it gives you a visual of what happens when you take that deep breath in, increased venous return, increased filling of the right ventricle. The free wall is not free to move, so the septum has to shift over to the left. Now we have decreased filling of that left chamber, and therefore you're going to have decreased aortic flow and decreased aortic pressure. This is just an ECG. If you know what the finding is here, I'll give you a second to look. This is classically electrical alternans, where you can look particularly in the top and bottom leads. You see that the QRS axis is shifting with each beat. That is because the heart is actually swinging inside this pericardial effusion, so that's changing the direction of the volts beat to beat. Rare, but neat if you see it. Okay, question 5, time to pause. This is a case where the physical exam finding is pathognomonic, and you absolutely need to know what that physical exam finding means. The correct answer here is HOCM, Hypertrophic Obstructive Cardiomyopathy. And the key piece of information is this early systolic ejection murmur that accentuates with Valsalva. That is basically pathognomonic for HOCM. Now, there's a lot of other clues here as well. He's 21 years old. He has no medical problems. He feels well. And this is a murmur that's found incidentally. Now, bicuspid aortic valve is also on your differential for a gentleman like this. And it's exactly this murmur physical exam finding that differentiates between aortic stenosis from a bicuspid aortic valve and HOCM. So this is absolutely something where knowing exactly the phrases for the physical exam finding is going to be key. This is a pathology specimen showing a very raging case of HOCM, where this entire septal muscle is absolutely massive, as is the free wall. And you can just imagine how this is going to be impairing flow out your aortic outflow tract here. So a few words on HOCM or HCM. It is often familial and autosomal dominant. If you're asked for a mutation, always choose the beta-myosin heavy chain when it comes to HOCM, because that is one of the most common mutations that we know of. There are others. This is when young athletes die. Usually it's because of HOCM causing sudden cardiac death from a ventricular arrhythmia. There are a few other things, of course, that can lead to sudden death in young athletes, but this is the primary cause. When it transitions from being hypertrophic cardiomyopathy to obstructive, that's when we have the asymmetric septal hypertrophy and the mitral valve anterior leaflet is getting pulled in towards the septum during systole, causing even more of a dynamic outflow obstruction so the blood can't get out through the LV, and that's what leads to your symptoms of dyspnea and syncope. Now, this obstruction of the LV outflow tract is dynamic. That means that it can change with volume. Unlike aortic stenosis, where you have a rock pile, that rock pile is not going anywhere. So no matter how you try to change preload, the flow is not going to be able to really change through that valve. It's fixed. But the obstruction in the HOCM case is dynamic, okay? So when preload is decreased, that means that the left ventricle is compressed more. It's not as filled. And so the HOCM is bringing closer together, more turbulent flow, therefore higher and more easily audible murmur. Does that make sense? So if you decrease the preload, the walls are coming closer together, you actually get more turbulent flow, and therefore you have a louder murmur. With hand grip, when you increase the afterload, that's going to make it harder for the blood to get out, and so therefore you have less flow and less of a murmur. So understanding that this murmur accentuates with Valsalva and knowing Valsalva decreases preload is key to differentiating between HCM and aortic stenosis. How do we treat this? Well, usually with beta blockers or verapamil is a treatment of choice, something you don't often see in clinical practice but relevant here. For people who have symptoms despite therapy, and those symptoms could be syncope, presyncope, or palpitations, there are options such as surgical myectomy, cutting that septum, or alcohol septal ablation. High-risk features get an ICD to prevent that arrhythmic death. Those high-risk features include family history of premature death, documented non-sustained VT, either on a stress test or when they're in a hospital for some reason, or on a Holter, syncope, abnormal blood pressure response to exercise, or if their walls are greater than 30 millimeters or 3 centimeters. These are all high-risk features that cause us to consider an ICD. Just a word on physical exam maneuvers. You can be held responsible on the board for physical exam descriptions. Valsalva decreases preload. Inspiration, as we discussed, squatting or passive leg raise, those are all going to increase preload. And then hand grip increases afterload. Knowing how those maneuvers change preload or afterload should help you predict how murmurs or hemodynamics can change. And these are very testable items. Okay, question 6, time to pause. Now you can pause again for the question. So this patient has what I call myopericarditis, or what anyone would call. We're combining the words myo and pericarditis because this is not just pericarditis. This is now involving the myocardium, and we know that for several reasons. The troponin of 15 tells us that the myocardium itself is inflamed. Okay. Now from the first description, triphasic rub, recent viral URI, and you're seeing diffuse ST elevations, you should have already been thinking about pericarditis. Then when we added in this rapidly progressive clinical course, she becomes tachycardic, tachypnic, hypotensive, she has JVD, she has a gallop and cool extremities. This is making you quite concerned that she is getting worse. The pulsus paradoxus of 5 millimeters of mercury, that's actually normal. We want it to be 8 or less. So that takes tamponade off the table, although you may have been tempted to think of that. Takotsubo cardiomyopathy is taken off the table because she's got global hypokinesis instead of that apical akinesis that I mentioned. Chagas disease would not present like this. An NSTEMI, possible, but her cardiac catheterization shows no obstructive coronary artery disease. And this term, NSTEMI, should be reserved in this case for using it when you're talking about plaque rupture MI. So really your best answer here is that myopericarditis. Now a word on myocarditis. This is inflammation of the muscle leading to myocardial damage and dysfunction. Coxsackie A and B is or was the major cause in the U.S., as you're probably very well aware. Coronavirus is also causing very robust and dramatic cases of myocarditis. In South America, T. cruzi, Trypanosoma cruzi, is a major cause of myocarditis. Now, this can be variable. They could be totally asymptomatic, or they can have sudden death. So the course can be different depending upon how dramatic it is. Arrhythmias are common, ventricular arrhythmias, because if you think about all the inflammation in between the myocytes and the ventricle, that's going to be a nidus for causing VT. And giant cell arteritis, giant cell myocarditis here is one of the main types that you see a lot of arrhythmia. So if you see someone in the the hospital or in the boards who's having a lot of VT and they're obviously in myocarditis, you should be thinking of giant cell. They're going to have an elevated troponin. They're going to be in heart failure, most likely from the decreased function. And we don't know this for sure, but a lot of people think that idiopathic dilated cardiomyopathy, meaning we find a low EF and we don't have a reason why, is probably a bout of asymptomatic myocarditis that left damage in the LV and only presents later when you get the symptoms of LV systolic dysfunction. Some non-infectious etiologies to remember: transplant rejection is a form of myocarditis from heart transplants, hypersensitivity from various drugs, although it's very rare, and then as mentioned, giant cell, where you actually see those multinucleated giant cells on biopsy, is a particularly dramatic one where you have a lot of ventricular arrhythmias. Here's what giant cell myocarditis tends to look like: a flu-like syndrome, and then very rapid fulminant progression to heart failure and shock. These people can go from feeling normal. In 2 days, they can be on ECMO or on other mechanical support in the ICU. Again, common is ventricular arrhythmias, rapid progression, and oftentimes fatal. We actually treat giant cell with immunosuppression. It's an evolving field, and there's a lot of different opinions and no great evidence. And you do need to get a biopsy because it can be seen, and because this is one of the few myocarditis that we are going to treat with immunosuppression. And oftentimes these patients need mechanical support or end up going to transplant. Okay, if you want to stretch, now's a good time to stretch. We're moving into category 2, arrhythmia. Pause. This is a multi-part, so here's the ECG. You can pause at any point. And here's the ECG now. Here is the question. Pause. And here's the answer. So the big change that you should have seen on these ECGs from here to here is QT prolongation. You can see it best probably here in lead V5, where you clearly see the end of the T wave blending into the P wave, but that's a very prolonged QT, particularly compared to where it was at baseline. And when you look at these medications, the main one that prolongs the QT is going to be that haloperidol. This is the dreaded complication of QT prolongation. You should recognize this as torsade de pointe, right, where you have that sine wave shaped turning of the points. This gets treated with electricity. It can terminate spontaneously, but it becomes ventricular fibrillation if not. This sometimes is the warning rhythm that something bad is going on. You are all very familiar with thinking about the magnesium and treating magnesium for torsade, but long QT is also one of those risk factors. There are some times that the bradycardia actually precipitates torsade, and that is because the longer time that you have, the more likely you can be to initiate a ventricular arrhythmia. And so the treatment for torsade can be to correct the bradycardia with pacing or isoproterenol. When I learned this first, I thought it was so strange that we were treating a tachycardia. This is a form of ventricular tachycardia, right? We were treating that by making the heart go faster. But torsade can often be pause or bradycardia dependent. So you want to shorten up that RR interval. That makes the QT interval also shorter and lessens the likelihood of going into torsade. So you either put in temporary pacemaker and pace them fast, or we can sometimes give them isoproterenol, which will also increase their intrinsic heart rate. This is just an ECG for you to practice because you should recognize this. This is monomorphic VT. There can be some debate. We could go through your algorithm to how to evaluate a wide complex regular tachycardia, but recognizing VT is important clinically, whether or not it would be on your boards. Next question. So, the next step in her management is reassurance. That is because this woman has Wenckebach phenomena, right? Or a second-degree AV block type 1. This is where her PR interval is there is relatively normal, maybe borderline long. Then it gets longer, and then it drops. Short, longer, drops. Short, longer, drops. You have a little 2-to-1 beat here where you drop the second one, but most of the time this is 3 P waves and 2 QRS complexes. So this is Wenckebach phenomena, or Mobitz 1. This is not a dangerous rhythm. The way I remember it, sort of my own mnemonic, is that you have a warning, right? Your PR interval is slowly getting longer, so there's a warning shot. Therefore, it's less dangerous. But this does not need any further workup, and this does not need a pacemaker. So this is just reassurance. You probably should avoid any kind of nodal blockade in these patients if possible, so you don't want to give metoprolol, but really it's good to recognize that this is not a dangerous rhythm. So again, here's looking at first-degree AV block, which is just a prolonged PR interval greater than 200 milliseconds, or one big box. Second-degree AV block comes in 2 flavors, Mobitz 1 or Wenckebach. This is where the PR interval is progressively longer, and then you drop a QRS complex after a P wave. This is an example showing you and calculating the PR interval, okay? And it's easiest to look at the one right before and right after the non-conducted beat to be able to see the difference between those two. Now, second-degree AV block Mobitz 2, this is where the PR interval is the same, and then the P wave is dropped and non-conducted suddenly, okay? So this is a little bit further down in the conduction system, and therefore it does not really respond to autonomic modulation, and this is a more concerning type of rhythm problem. So here we can see a constant PR interval, and then all of a sudden, out of the blue, one of the P waves is not conducted. So this is going to be Mobitz 2, second-degree AV block. And then finally, we have third-degree AV block. This is where none of the atrial impulses or the P waves are communicating down to the ventricle. So you're having the A and the V, the atria and the ventricle, beating independently of one another. Your PP is going to be the same. That's because the atria is just going along. So P wave, P wave, P wave, P wave. The RR is also going to be constant. QRS, QRS, QRS. And there's no relationship between these two. They are not talking to each other. By definition, the atrial rate will be faster than the ventricular rate. That's because normally the AV node slows the conduction between the two. So the intrinsic atrial rate is going to be fast, and then the QRS complex is going to be slower. And depending upon where in the conduction system you're getting your ventricular or your escape beat from just below the node, that will determine how fast that QRS is going. So here you see these regular P waves, boom, boom, boom. One is hidden in there, boom, boom, and they're just marching along. And then you have the QRS complexes, and they're going at different speeds, no relationship to one another. So that's third-degree AV block. And here's the P waves marching out. Okay, next question. Here's this ECG. And here's the question. You can pause to think. So this woman is having highly symptomatic rapid AFib. You should recognize this: irregular, narrow complex tachycardia. That's AFib until proven otherwise. She is not doing well. She's hypotensive, tachycardic, tachypnic, hypoxic. She is cold to the touch, and she is not perfusing her brain. There is no mystery here. You have to get her out of this AFib, and you have to do it now. So you don't have time for a lot of these medications, which are going to take some time. Definitely can't give her anything PO. She's also hypotensive, so you want to avoid diltiazem or even esmolol, which in my experience does drop the blood pressure, no matter what the package insert says. Adenosine is only going to interrupt AV conduction, but that is not going to help us with interrupting the AFib. So that's the wrong choice. And IV amiodarone, although we do that when someone is peristable and has a little bit of blood pressure to work with, I gave you no choice in this question, but to know that she's unstable and needs immediate cardioversion. Synchronized is important, right? You want to make sure you press that sync button so that the shock is not delivered in the wrong part of the cycle and leads you into VT or VF. So a few words on AFib or aflutter. Remember that our treatment strategy is rate control. We have various options that we can use, but we have to be careful given the patient's comorbidities. There's also rhythm control where we can cardiovert them back into sinus, either with electricity or with medications. The most common that you are going to see in your ICU or in your medicine practice would be amiodarone. We have others that we do as cardiologists, but less important for internal medicine. And then never forget about your anticoagulation. Look at the options in terms of warfarin versus your NOACs, or now just called DOACs. They were novel. That's where the N came from when I was in training. And now they're just called DOACs because they're direct oral anticoagulants. So remember to calculate your CHADS VASc score and initiate anticoagulation with appropriate therapy. This is an ECG. Just take a second and be able to recognize this rhythm. That rhythm is atrial flutter, for those who did not know. You have your typical downgoing sawtooth waves in your inferior leads, and you have variable conduction. That's why the QRSs are irregular. Okay, next question. This is a pure recognition question. This pattern of a scooped ST segment, people often say this looks like a sailboat, which this being the boat and this being the sail. This is a classic sign of digoxin toxicity. And this is something you just need to be able to recognize. Boards questions do love asking about digoxin, even though it is falling out of favor in clinical practice, because it has such a narrow therapeutic window that toxicity is common if you don't watch things closely. If you actually become dig-toxic, the classic symptoms are nausea, vomiting, anorexia, yellow halos. There are hypotheses that Van Gogh had digoxin toxicity towards the end of his life, and that's why he started painting in yellow more, because he was seeing these yellow halos. And then people just feel pukey and nasty. On ECG, you're going to see several different things. You can see heightened vagal tone, so slower. Increased automaticity, so it's just going on its own. Regularized AFib, meaning no P waves, but you just have a QRS. That's very common or classic for dig toxicity. And then these scooping ST depressions that I mentioned. Here's an example of regularized AFib. There's no P waves, but your QRSs are normalized. Atrial tachycardia with a block is also possible, but probably beyond the scope of your boards. Bidirectional VT, or having wide QRS complexes in different with different vectors. That's also possible from dig toxicity. I think the scooped ST segments that I showed you is probably going to be the most testable one. Okay, again, time for a pause. I'm going to pause as well so that the sunshine can get out of our way. All right, I've paused. The sun is somewhat in my face, but we'll be leaving shortly. Now let's go back to our next section, which is ischemia and atherosclerosis. Question, time to pause. All right, so this is a very classic question that boards love to ask, where the board's answer might be different than what you actually would do in practice. So this is a gentleman with chest pain. It is stable anginal type pain, right? It's occurring with 2 flights of stairs resolving with rest. His risk factor is hypertension. EKG is normal. That's really key here. With a normal EKG, in someone like this, they actually recommend an exercise stress test without imaging. Now, in real life, most people add imaging because it does increase your sensitivity and specificity of the test. But for the boards, if you have a normal EKG and you don't have significant number of risk factors, this is going to be someone who just gets a treadmill. It does happen in the real world, but most of you are probably accustomed to adding imaging. You would not go straight for angiography because this is very stable and because he is sort of intermediate pretest probability, so a stress test will give you good information. You could do a nuclear test, but you actually and you could do regadenoson, a vasodilator, but you prefer for this gentleman to exercise. You want the physiologic information to see what happens and can you mimic the pain he gets when he walks 2 flights of stairs. Exercise stress cardiac MRI exists in certain places, but that's probably overkill in this instance. So most of you are probably trying to choose between D and E, and this was one of those tricks where because the EKG is normal, you can interpret the EKG. Okay, next question. And here is your question, so you can pause and go back if you needed to read. So the correct answer here is atorvastatin, okay? This woman is coming in with chest pain, all the risk factors, already has known coronary disease. She has troponin elevation, her EKG showing ST depression, so you know that this is an NSTEMI for all intents and purposes. She's given great medications, aspirin, an antiplatelet agent, beta blocker, and an anticoagulant. These are the ones that most people think of, but don't forget the importance of statin, and early statin administration actually has shown mortality benefit. Now, she does have some non-sustained VT and some PVCs, but amiodarone not indicated at this time, and statin is the life-saving one. She's not in heart failure, so you don't really need Lasix. Nitroprusside, only if we're thinking cardiogenic shock with a high SVR. And spironolactone, we do give this in the acute setting for MI if they have a low EF. You usually don't know that information until after they get their angiogram. So just to remember, how do we treat NSTEMIs or unstable angina? So again, anything in that ACS category. You may have learned MONA. I sincerely hope that you haven't. And if you have watched my ischemia lecture, you know how I feel about that, which is that this acronym is totally useless because it includes so many things that don't have mortality benefit, okay? Morphine, only if we need to, and it probably decreases absorption of our antiplatelet actions. Oxygen, only if they're hypoxic, and hyperoxia causes worse free radical damage to the myocardium. Nitroglycerin, yes, we can give it, but no mortality studies. Aspirin, that's the only one on this list which does anything for mortality. So all of those things, aspirin's the only life-saving one. Instead, I use the ABCs. An antithrombotic, okay, so that's going to be my anticoagulant. IV heparin, going to be your most common one. Aspirin, your antiplatelet agent. So you're going to be thinking of clopidogrel, prasugrel, ticagrelor, one of these. The anti-anginal is in gray because, yes, we can give nitro to help with the anginal pain, but just remember it's not life-saving or not proven to be life-saving. ACE inhibitor is in my treatment regimen if they're hypertensive and their kidneys can handle it, because this is good for people if they have low EFs. Beta blocker, definitely, if I can tolerate it up front. And then I use my C as cholesterol, which is to remind me to give them high dose or high intensity statin right from the beginning, regardless of what their LDL is. Next question. All right, so this is trying to get at understanding about complications of acute MI. These types of complications have gone down in incidence quite a bit, and you may have never seen one in your training. That's because we've done such a good job of getting people to early revascularization, which can help to prevent these things. But if you'll notice, this patient who I switched from being a female to being a male, I think, at some point. But anyway, this patient has had 2 days of pain. And that is a late presentation, which increases your risk for these mechanical complications. Huge troponin, low EF, inferior akinesis. Okay, then suddenly, boom, sitting in your CCU recovering, acute onset shortness of breath, hypotension, tachycardia, sick, not good. Okay, tachycardic and regular, in heart failure with crackles. So you're definitely going to give this person diuretics, but then you need to think about what else. Well, almost no matter what, you need to get an echocardiogram because that's how you're going to diagnose one of the mechanical complications. Now, people will think about repeat coronary angiography if they're going into shock because that stent was occluded, but we should see something on our ECG. ECMO, well, that's only if we can't get control of the situation. Balloon pumps, you're going to see them used, but according to the SHOCK 2 IABP trial, they do not have mortality benefit in cardiogenic shock. If she were an AFib and the AFib were driving this whole scenario, you might do cardioversion. But in this case, that sudden deterioration with shortness of breath means I need an echo to look for a mechanical complication. So what might those be? Well, there are ruptures, like acute mitral regurgitation from a pap muscle rupture, a ventricular septal rupture, or a free wall rupture. None of these are good to have. And then technically, an RV infarct or RV failure is seen as a mechanical complication of an MI. So let's see real quick about this acute mitral regurgitation. There are two mechanisms. One makes sense, pap muscle rupture. If your pap muscle gets ischemic, 2 days later when all of your inflammatory cells are coming in to clean up the debris, that makes it mushy, it ruptures. Now you have a wide open leaflet that's swinging in the wind. But the other mechanism of acute mitral regurgitation in the setting of acute MI is called tethering. This usually happens when the inferior wall is hypokinetic. So normally during systole, which remember that's when the mitral valve is closed, the entire heart will be squeezing like this. And when it squeezes, that's part of how those chordae tendineae are keeping the mitral valve closed and from ballooning back. But when the inferior wall is hypokinetic, it's not squeezing. And so it's essentially pulling on that mitral valve leaflet and tethering it so that it cannot coapt with the other one. Okay? And so that's going to give us acute mitral regurgitation because of the ischemia of the inferior wall, not necessarily because of a rupture of pap muscle. The timing for all of these mechanical complications, especially the ruptures, is about 2 to 5 days. That's again because of this inflammatory infiltrate. And if it's mitral regurgitation you're dealing with, you should have raging pulmonary edema because all of a sudden a lot of the LV outflow is going backwards into the lungs. You may hear a murmur, but you may not. If it's really wide open and you don't have turbulent flow across the mitral valve, you may not hear a murmur. You, of course, need to put an echo probe on the chest. Sometimes we have to go for TEE in order to see things clearly and to really understand the severity of the problem. And then really, surgery is going to be your treatment for this. We sometimes try to get them through with some of these temporizing measures that are basically afterload reducing. If we can afterload reduce, we can try to force some of the LV outflow to go into the aorta instead of backwards, but the pressure inside the left atrium is going to be 10 or 15 millimeters of mercury in this instance. The pressure in the aorta is much higher than that. So it's very hard to manage this complication with vasodilators alone. Here's an image showing us the left ventricle, the left atrium, right ventricle, right atrium. This is going to be a TEE, so it's probably reversed if you're accustomed to looking at transthoracics. But what you can see is this thing in the left atrium. This is a hunk of pap muscle. And when we put color across the valve, you're seeing this wide open, turbulent flow, severe mitral regurgitation. So this, in combination with your floating pap muscle in the wrong chamber, suggests pap muscle rupture. And here's what that might look like on pathology specimen at autopsy, where you have your pap muscle, your chordae tendineae, and your mitral valve, and then here you see that the muscle has ruptured. This is a great schematic showing that tethered pap muscle phenomena that I was talking about. So here is when that hypokinetic inferior wall is tugging on the mitral valve and not allowing this posterior leaflet to coapt completely with the anterior leaflet, leaving an opening for regurgitation. So really like that schematic to help understand it. Another type of rupture will be a ventricular septal rupture. Again, timing will be 2 to 5 days. This one is bad news. Bad news. The mortality is very high. Surgeons are very reluctant to take these patients to the OR because what they tell me is that it's like trying to sew wet tissue paper together. And they try to give a lot of time for some healing and some fibrosis in that area so it's easier to sew. But of course, time is not always the friend of these patients. This, unfortunately, is one of my patients. You can see that this woman had long-standing hypertension with her LVH, but she had this ventricular septal rupture. The probe should not go through between the two chambers. But what you also see is this is in the area of the infarct, right? And so the inflammatory cells came in and started chewing up your necrotic debris, and that's when it ate a hole through the myocardium. Management for VSR is good luck and a prayer. You are going to potentially feel a thrill. So you could feel that turbulent flow with your hand when you put it on their chest. If you do a right heart cath, you're going to find a step up in oxygen saturation, right? Because the oxygenated left ventricular blood is now coming into the right ventricle. If you see a difference of 7% from the vena cava to the right atrium or 5% from right atrium to RV, that is characteristic of some communication left to right. In that woman who I showed you the picture of, her step up was like 25% because she had so much blood coming from the left to the right. And echo, again, is going to be your diagnosis. If you have time, if you're lucky, if you can try to give them vasodilators that might decrease the left to right shunt, but only if they have blood pressure room to work with, that's possible. These patients often have concomitant left or right ventricular failure, so might need inotropes. And then if they are hypotensive, then you can't give them the vasodilators, they might need pressors. This is, again, impossible to manage a mechanical problem with medications, but sometimes we try. Mechanical support, the woman I showed you, was on ECMO for a time. Unfortunately, she did not survive due to complications. And then if you can convince the surgeons to take them, surgical correction. Sometimes we now started putting plugs into that VSR through interventional cardiology, but they are even more reluctant than the surgeons are to do so. And then free wall rupture. This tends to be a little bit longer, 5 days to 2 weeks. But if you have a post-MI patient with sudden collapse and an effusion, you must think about free wall rupture. This one is kind of nuts to manage. You want to alleviate the tamponade that's happened because the free wall rupture is causing hemopericardium, right? Blood in the pericardium. So you want to alleviate the pressure in there, but you don't want to just create a vacuum. If you put a straw and suck out the blood, you could just suck out your entire cardiac output through that pericardial drain. So usually the recommendation is emergent pericardiocentesis, alleviate the pressure just enough to alleviate the tamponade, then clamp it off, and then when they again go into tamponade, unclamp and drain. So don't do a continuous drain. And then emergent surgery here, but mortality again is very high. This is a picture of a free wall rupture, and you can see some contained hemopericardium surrounding it as well. Next question. So this is trying to indicate a right ventricular infarct. So inferior STEMI, okay, that's making us already think about the RCA. She is pukey, nasty, hypotensive, feels bad, bradycardic, cool to the touch. A right-sided ECG is very useful, and what you really want to be looking at is V4R. This is where you just switch the ventricular or the precordial leads and put them over to the other side. This ST elevation in V4R is very predictive of a right ventricular infarct, okay? So here we're showing the inferior STEMI, and we're showing that it's the RCA because lead 3, which points towards the right, is higher than lead 2. That gives you an RCA with about 97% sensitivity. So the RCA is involved. And then if we switch over to right-sided leads, notice that your limb leads don't change at all because these are from the limbs. We've only switched the precordial leads. And when we switch those, V4R is elevated, and that gives us the diagnosis of an RV infarct. These patients are sick. If you see that V4R elevation, you know you're in for a wild ride. It has about 80% positive predictive value. They develop arrhythmias, shock, heart block, temporary pacemakers, swans, balloon pumps. These people are sick, but the great news is that they often recover within 48 hours. They are preload dependent. The RV has become a soggy bag that the blood is just flowing through, so you have to squeeze more into it. Keep the CVP up. Hemodynamic monitoring. They often need inotropes. Of course, reperfusion is the first treatment for all of this. And oftentimes, they will need a pacemaker because they will go into arrhythmias or heart block if the node is involved, and they do not tolerate the arrhythmia as well. I put this up on a separate note because this is a rhythm that not a lot of people see, but it's an important one to know. If you were describing this, you would say that this is a wide, complex, regular, but then you'd have to stop at tachycardia because we're just right under about 100, we're actually under 75 beats per minute. So it is not technically ventricular tachycardia, but it also doesn't look like a normal bundle branch block. And if you try to find P waves, good luck, you can't see them. This, although looks at first glance like maybe that's a scary rhythm, this is actually what we call a reperfusion rhythm. It's called AIVR, accelerated idioventricular rhythm. Accelerated because it's coming from the ventricle, and usually a ventricular escape rhythm is 20 to 40 beats per minute. Idioventricular because, again, it's coming from the ventricle. This used to be one of the things that cardiology fellows would look for after they pushed lytics. They would look for ST segments to come down by 50%, and they would look for this rhythm. You might see this when someone comes to the unit after they've been reperfused from a STEMI. And don't freak out and don't start them on amiodarone for this. This is a good rhythm saying that the myocardium is being reperfused, and so this should be transient and self-resolving, but a good one to know and keep in your back pocket clinically. Next question. All right, so this is a person who has anterior STEMI complicated by some shock. And we know that they have shock by the low cardiac index of 1.6, but even before that, he has decreased urine output, confusion, and he's cold. This makes us very concerned. Blood pressure is borderline, but the heart rate is about 80, okay? So when we see this, we have elevated right and left-sided pressures, the wedge pressure and the CVP are up, and we have the low cardiac index. This person definitely needs diuretics. And then the question is, what kind of inotrope do they need? I only really gave you one pure inodilator, dobutamine. Milrinone is another option clinically. I purposely didn't include it here because there wasn't anything to push you one way or the other. Phenylephrine, this is going to be a vasopressor, so we only use that if they're very hypotensive, and it doesn't get at the real problem, which is the low cardiac index. Epinephrine, this is the big gun. It should only be used when they're refractory to other inotropes. Vasopressin, again, this is going to be a vasopressor. That's not what we need here. Nitroglycerin, a vasodilator, also not what we need. Now, you may have noticed this temperature, which could have thrown you off and made you think that this was a septic patient. I will tell you that 48 hours after a large STEMI, almost all of the patients get an elevated white count and a temperature. This is almost never from a true infection. Of course, we send cultures and usually people start them on antibiotics, but this is from the very highly inflammatory post-MI state that people get. So don't be fooled by the temperature, do an appropriate workup and evaluation, but maintain your high index of suspicion that cardiogenic shock is going to be far more likely than septic shock in this person, particularly someone who is cold to the touch. You should probably know your hemodynamics and what normals are. I like to use this chart to help me remember. I think of nickels, quarters, and dimes because I use those as my normal numbers. So in my right atrium, it's a nickel, 5 millimeters of mercury. Right ventricle, quarter over nickel. Pulmonary artery, quarter over dime. Left atrium, dime. Those are pretty much your normal pressures. If you have those memorized, then you can know what are elevated. Cardiogenic shock, perhaps my favorite subject. I think people have a hard time making this diagnosis and are so used to seeing septic shock, particularly in an internal medicine residency, that they miss the cardiogenic shock. What you want to do is think of this person as though you have a swan or a PA catheter and try to, when you're at the bedside, determine, do I think their cardiac output is low or high? Do I think their systemic vascular resistance is low or high? Wedge pressure. Evaluating those things at the bedside is going to help you determine whether they're in shock, what type it is, and how to treat it. They need lots of monitors, and again, we want to treat what the underlying cause is. If they have volume overload, give them diuretics. If they have low cardiac output, give them inotropes. And if they have high systemic vascular resistance or high afterload, give them vasodilators. I have a whole lecture on shock where I really hammer this in, and I encourage you to watch that. I have this little chart that I help myself to remember about the inodilators or inotropes, particularly dobutamine and milrinone. They act by different mechanisms, but the main thing to think about here is that dobutamine often gives you tachycardia and tachyarrhythmia, whereas milrinone often gives you hypotension. And knowing those two side effect profiles can help you understand which one is the better choice, since they are more or less interchangeable in terms of therapeutics. Next question. Pause. Okay, so this is a person who has peripheral vascular disease and claudication. All the risk factors, all the medications. The whole point of this is to remember that although you might do all of these things, you might want to do all of these things in your clinic. Smoking cessation for sure. Improve glucose control. Maybe his A1C is not that bad. Getting his blood pressure under control. Getting him on a high-dose statin. You're probably going to do all of those things. But the thing that improves symptoms of all of this is exercise program, building collaterals. This is just looking at the risk factors for peripheral arterial disease. Remember that atherosclerosis is a systemic illness. These are all of your risk factors for coronary artery disease, right? So if one vascular bed is affected, it's highly likely that others are going to be affected as well. However, smoking really leads to peripheral arterial disease even above and beyond coronary artery disease. Diabetes is a big one, hypertension, all of these as we mentioned. So don't forget about other arterial or vascular beds, and the boards won't let you forget about them. You'll be tested on them. The medical management of stable peripheral arterial disease, you want to think about all of the above. Risk factors, medical therapy, and an exercise program. We already mentioned all the ways to modify the risk factors. Aspirin is really the mainstay of antiplatelet therapy unless they have another indication for a different antiplatelet or if they've been revascularized with peripheral stenting procedures. And then finally, exercise program is what's really going to change their symptoms. Next question. So this is a classic internal medicine question. This is a 70-year-old gentleman with a history of smoking. And anybody in that category needs a one-time abdominal ultrasound. And what are you looking for? AAA. Okay, so pulsatile abdominal mass, hopefully it doesn't get to that point, and you diagnose this on routine screening. If the U.S. Preventive Services Task Force recommends one-time screening, male ages 65 to 75 with any history of smoking. Everybody gets just one of these. If you find it, you need to monitor it. If the diameter is greater than 5.5 centimeters, straight to the surgeon they go. If it's increasing by 0.5 centimeters per year, to the surgeon they go. There are many different options, open versus endovascular. This is a fantastic picture showing this infrarenal AAA. Again, you hope that you catch this far before it gets to the stage of being a pathology specimen. Okay, again, a stretch. We're on to valves. We're making great timing here. Here's your question. All right, so this is getting a little bit back to that HOCA murmur that we talked about. Very fair for you to get a history, a physical exam, no echo findings, and really need to diagnose this. So what are the key points in this feature? She's 59 years old, so she's a bit young for true aortic stenosis. You have a little hint. Aortic aneurysm and root repair, suggesting some kind of vasculopathy, aortopathy, which tends to go along with bicuspid valve, okay? So we have this systolic ejection murmur, crescendo decrescendo, so we're thinking about our aortic valve. This murmur decreases in intensity with Valsalva and increases with passive leg raise. This is the opposite of what we saw for the HOCA murmur. So this is making us think about aortic stenosis, okay? There's also a diastolic murmur. This is going to be the regurgitation that's coming through that aortic valve as well, because these bicuspid valves can do both stenosis and regurgitation. So this should have been, based on your exam, between A, B, or maybe D. You might have been tempted to think about mitral stenosis with a diastolic murmur, but you should not have also had this systolic murmur as well. Again, she's too young for calcific aortic stenosis, so we're really between aortic valve and HOCM, and the physical exam telling us that the murmur decreases with Valsalva puts you to bicuspid aortic valve. Next question. So this one calls upon multiple different understanding. This person has, this is the same patient. She has that bicuspid valve that we talked about, okay? There is severe AI, so it's time to replace with the severe AI. These numbers actually matter. 50% EF, that's right on the border for AI, but she started to enlarge. She's above 50 millimeters on her LV, so it's time to replace. However, she also has a large ascending aortic diameter of 50 millimeters. So when you're at that point, you're already going to be replacing the valve, and your ascending aortic diameter is 50 millimeters, you actually do both the valve and the ascending aorta. So to talk about aortic stenosis, you should know these classic symptoms: angina, syncope, dyspnea, ASD. These have prognostic significance, but more likely what you're going to find is that people start to self-limit and they exercise less. So they used to be able to walk around the mall. Now they have to stop more frequently. It might even be more subtle. They used to mow the grass with a push mower. Now they only do the riding mower. That's going to be more likely the story because they learn to adapt to the fatigue and the dyspnea. I love to show this because this graph is from 1968 and nothing has changed. As soon as you have symptoms with your severe aortic stenosis, that's the day when your mortality starts to plummet. And it plummets with angina, syncope, and dyspnea or heart failure. So with angina, you have the best prognosis, syncope in the middle, heart failure symptoms, there's only a 50% 2-year survival. So what do? Well, if you find aortic stenosis and they have no symptoms yet, you need to monitor them for the progression of severity and ask them good questions about their exercise tolerance because that might be the first clue. We can treat the associated conditions, but that is not going to change the mortality from aortic stenosis. And a lot of these patients have coronary disease, so you usually need to do an evaluation to see if the symptoms are coming from coronary obstruction or from aortic stenosis. Okay. So again, you should refer for replacement when the patient is symptomatic, or if they're going to have other surgery, right? Bypass surgery or other valve procedures, then your threshold is a little bit less. Okay, so this is important that once you have severe AS, they're going to get worse. At 1 year, 80% of them will not have symptoms or an operation, but that rapidly declines. So if you find severe AS, you need to be on the lookout and watch these patients very closely because you might miss your chance to send them for surgery and give them that mortality benefit. Now, aortic insufficiency, on the other hand, again, looking at when would you replace it. Acute severe AI, like in the setting of endocarditis, good luck. But if they have chronic severe AI, they need to either have symptoms or their LV starts to decline. So if their EF is less than 50% or it starts to dilate, 50-50, 50% or greater than 50 millimeters, that means the LV is getting affected. It's time to replace the valve before that LV remodeling gets out of control. And then again, if you're undergoing some other surgery, reasonable. All right, same patient, next question. So, mechanical valves have to use warfarin for their anticoagulation. DOACs are not in use in this country and not studied. In Europe, you might find that. This question is getting at the INR goal for aortic valves versus mitral valves. The goal for aortic valves is 2 to 3, okay? This is a high flow area, and blood flow is the best anticoagulant. So with all that flow going through, you need a lower INR. The mitral valve is a low flow area and therefore more prone to clotting, so you have a higher INR goal. Plus, if you have any other risk factors like AFib, hypertension, coronary disease, you also get aspirin with that mitral valve. Okay, so again, mechanical valve, here we talked about aortic versus mitral, the INR goals, and that the risk of thrombosis is much higher on a mitral than an aortic valve. When I see a mitral mechanical valve patient who's off their anticoagulation, that is much more concerning to me than the aortic valve patient. It is very likely that you could get a question about prosthetic valve anticoagulation and pregnancy. It is a challenging thing to do, okay? And the newest guidelines actually differentiate between patients who need 5 milligrams or less of warfarin or more than 5 milligrams, okay? Because warfarin is not preferred in pregnancy, but if it's in a low dose, then you can wait all the way until the end of pregnancy to switch to heparin. If it's in a higher dose, then you might need to switch to Lovenox injections, which is not fun to do. Okay, next question. Pause. All right, so this question is quite long and requires you to do multi-step reasoning. 32-year-old woman who's pregnant. For me, as a cardiologist, I'm always worried about pregnancy bringing out cardiovascular disease. She clearly has some volume overload, and this physical exam, my Diastolic low pitch tremor at the apex rating to the axilla, combined with the fact that she's a young pregnant woman from Ghana, I should already be thinking mitral stenosis. And that is in fact her diagnosis. Now I gave you echo findings. You would not be expected to know the normal gradients on an echo for internal medicine, but you should already know that this is mitral stenosis based on the exam. And when you hear this, reduced posterior mitral leaflet excursion, significant calcification, that's all leading you to this diagnosis. Now, very important for mitral stenosis is understanding how to treat it. And I like to think of that about pregnancy to help me understand how to treat it normally. Remember that mitral stenosis means you have less flow getting into the left ventricle during ventricular diastole. You'd like diastole to be as long as possible so as much blood as possible can fill. So beta blockers, if you slow the heart rate, you spend more relative amount of time in diastole, you get more filling. And then because she's in heart failure, and especially in pregnancy, with that increased circulating blood volume, you need diuretics. I added on here, reevaluate biweekly. This woman is not yet at the point where she needs intervention on that mitral valve, but she is only 25 weeks pregnant. She's already quite symptomatic. Those symptoms are going to get worse by the week, and it is very likely that she is going to be fine, fall off the edge in terms of heart failure symptoms. And so mitral balloon valvuloplasty is often what ends up happening for these pregnant women to get them through the pregnancy, but you have to watch them very, very closely. These are the classic physical exam findings of mitral stenosis: low-pitched diastolic rumble, opening snap, loud first heart sound. These are the types of pathognomonic sayings that if you read them in an exam question should be raising your suspicion for mitral stenosis. Okay, now again, how do we treat this with our replacement? Well, if they are symptomatic with moderate to severe mitral stenosis, or if they have severe mitral stenosis with elevating pulmonary pressures. This is akin to when you're starting to see the LV have dysfunction in aortic valve disease. If you're starting to see the backup of pressure into the pulmonary vascular bed, you'd like to stop that process before it gets out of control. Okay? This balloon valvuloplasty, where we just blow up a balloon inside that chunky calcified mitral valve, this is actually preferred because you can get 5 to 10 years out of it. But you need to be a good candidate, and you cannot have significant MR or lots of calcium that's going to fly and cause strokes. So in general, with valve disease, it's pretty easy. If they have symptoms and severe disease, it's time to do something about it surgically. If the LV is starting to either fail or dilate, do something about it. If they're getting other surgery, go ahead and replace it so you don't have to go back into the chest. The numbers to remember for aortic insufficiency is 50-50. EF less than 50, diameter and diastole greater than 50. For mitral regurgitation, 60-40. This is different because with MR, remember that when your LV is squeezing, a lot of that is going backwards into the left atrium. So an EF of 60%, well, much of that is going backwards. So your effective forward EF is much lower. Therefore, your threshold for treating is when the EF is higher, less than 60%, or dilation greater than 40 millimeters. Okay, final stretch, last category here, miscellaneous. Pause. All right, so pre-op evaluation, definitely the realm of internists. This guy has a lot of risk factors, and you can definitely calculate some risk scores on him, right? But the key here is that he is able to climb 1 flight of stairs with no dyspnea or chest pain. That means he can achieve about 4 METs. And if someone can achieve 4 METs, there is no need for stress testing, okay? Stress testing prior to surgery, it also turns out, even if you get a positive stress test and you revascularize the person, it is not going to improve their prognosis. So it's really reserved for cases where you cannot assess their functional status at all, and we really rarely do anything about it unless we find very significant coronary disease. So with good exercise tolerance, he's already on a beta blocker and a statin, which are 2 medications that have perioperative mortality benefit. Therefore, just let him roll. This is an algorithm for how to approach that perioperative cardiac assessment. So again, if they're low risk, no testing. Elevated risk, but they can have good functional capacity, then no further testing. But if they have poor or unknown functional capacity, and you would do something about it, okay? So if the person's limb is falling off, you're going to revascularize the limb, and you're not going to delay for some stable coronary disease, okay? So only if it will change the outcome, then you can do a pharmacological stress test. Next question. Here's your image. Multi-step reasoning. Here's your question. So this patient is something pure recognition. This is the aortic dissection. Okay. The patient is not doing well. I've given you some nice physical exam findings to suggest Marfan's. Okay, blood pressure equal in both arms. It does not deter you from the diagnosis of dissection. That's a very low sensitivity test. The CT scan, you should be able to recognize the dissection flap, the true lumen and the false lumen. And this is a patient with Marfan's, and their genetic mutation is fibrillin 1. Very fair question to know for the boards. Okay, now for this patient, what's the most appropriate management? Well, this person has an ascending aortic dissection, so needs emergent surgical intervention, okay? So the different types, type A is right above the aortic valve in the ascending aorta. Type B is past the ligamentum arteriosum. Type A's can also dissect towards the heart and dissect the RCA. This is very bad news. You also have probably heard of the DeBakey types. For the most part, we just use type A and type B. Type A is anything involving the ascending aorta. Type B is if it doesn't involve the ascending aorta. Okay, so how do we treat them? Well, we try to stabilize them first in the ICU. IV labetalol is the agent of choice. It's going to lower the blood pressure, the heart rate, lower the stress on the wall. It's going to keep that dissection from propagating, you hope. So you get them into the ICU with an ART line, a central line, you give them that labetalol, and you try to drive their blood pressure and heart rate down. In general, we avoid vasodilators. It can be hard to control the blood pressure without sometimes, but we try. And then type B usually are managed medically unless they're having ongoing pain or you start to dissect into the renal arteries, for example. Type A, these are a surgical emergency because if you dissect those neck vessels, you can get stroke. If you dissect the coronary, you can get an MI or tamponade. So type A's are sent to the OR as soon as possible. Next question. Okay, so this is something purely to know is which patients get antibiotic prophylaxis prior to dental procedures, okay? And there is this chart, anyone with a prosthetic cardiac valve, indwelling prosthetic material, previous history of endocarditis, and then the congenital heart disease is where it gets a little bit trickier, okay? Unrepaired cyanotic disease, right to left shunts, completely repaired disease within 6 months after the procedure, okay? Or if they have prosthetic material. And then finally, repaired disease, but if you have residual defects right next to a patch or a device. So those are a little bit tricky to know, but in this case, it was very clear that this guy with a bioprosthetic or prosthetic valve needs the surgical prophylaxis. Okay. Mitral valve prolapse, that used to be of interest for prophylaxis. It is not anymore. Next question. All right, so again, this is just purely memorization, and the key phrase in this presentation is fixed split S2. A fixed split S2, that is an ASD, pathognomonic. And so if you see that anywhere, you know that you're dealing with an ASD, and that's just simply something you got to know. Now, on exam, again, fixed split S2 with ASDs. You often will see increased right-sided volume from the left to right shunting. The most common is ostium secundum, okay? That's actually the most common type of congenital heart disease, and it can occur in isolation, not with any other defect or disease. And the symptoms are due to left to right shunting, so volume loading of the right side. Next question. So this is just recognition of venous stasis. You may have been tempted in this patient to think about arterial insufficiency. He's not a smoker, doesn't have diabetes, so not a diabetic foot wound. And I gave you an ABI of 1.1, which is normal. Usually arterial insufficiency ulcers are going to be more distally towards the areas where the blood flow is hardest to get. You also are going to lose hair for arterial insufficiency and have shiny skin, okay? This is a venous stasis ulcer. You can see the sort of denuding of the epithelium. You just have to be able to differentiate pictures between other types of wounds or ulcers like pyoderma gangrenosum or erythema marginatum, which have very classic and particular patterns. Next question. So this is understanding how to treat hypertension in pregnancy. It's also understanding some of the definitions, okay? So there are different types of high blood pressure during pregnancy. Chronic hypertension is if you had high blood pressure or you're diagnosed before 20 weeks of gestation, okay? So this woman is at weeks 12 and 16 and she's hypertensive. So this is considered chronic hypertension. There's also preeclampsia or eclampsia. That's when you have the hypertension plus proteinuria beyond 20 weeks. Okay, you can get preeclampsia on top of chronic hypertension. That's when you add in the proteinuria after 20 weeks. Or gestational hypertension, high blood pressure in the absence of proteinuria greater than 20 weeks of gestation. So those are a lot of things to keep straight, but very testable material. In fact, hypertension is the single highest represented subject on the ABIM under cardiovascular. Okay, so what do we do about it? Well, the practice guidelines about choice of agent differ from society to society. If the blood pressure is above 160, you have to treat. Labetalol is really kind of considered as a frontline therapy. Any beta blocker is okay, but not atenolol because of its non-specific nature. Nifedipine, methyl-dopa, these are allowed. You will see methyl-dopa quite a bit, okay? Second line is diuretics. They're not necessarily dangerous to the fetus, but they do cause volume depletion, which can be dangerous. If someone's in severe hypertension and hospitalized, you can consider these IV agents. And then hypertensive crisis, you can go on to nitroprusside or nitroglycerin. It's important to know what you cannot use to treat, which in specific is atenolol and then ACE inhibitors or ARBs because of the possibility of fetal renal abnormalities and lung. Also, some societies say that if you're already on a diuretic before pregnancy, then you can continue it. So you can choose from amongst these agents, and if they're already on one agent, continue it. But if you remember in the prompt, this woman was on HCTZ at one point but wasn't currently taking it, so then you would prefer labetalol, nifedipine, or methyl-dopa. Okay, that concludes our board's review. I like these demotivating posters. This says, interns, the experience we're giving you is invaluable. That's why we're not paying you anything. And in fact, you have to pay to take this board exam, but I hope you feel a little better prepared for the cardiovascular section now, and you can come back and use these questions to practice for yourself. Practice going through the various answer choices and saying, how would I have to change this patient or this prompt in order to make this answer correct? That's a way to get more mileage out of the questions. Wrap your brain around it. Make sure you really understand it. Thanks for joining in, everybody.